Hello there. This is part 2 for motor neuron disease. In today's lecture, we will be discussing about clinical features of motor neuron disease. The clinical features of motor neuron disease can be a mixture of upper motor neuron as well as lower motor neuron pathology. So first of all, we will be discussing about impairments related to lower motor neuron pathology. For impairments related to lower motor neuron pathology, the clinical features are: there is a focal impairment. That means the weakness can begin in one of the muscles of either upper extremity or lower extremity, or there is a weakness in the bulbar muscles, that is the muscles supplied by the cranial nerves. The weakness may begin in one of the muscles distally and it can slowly progress proximally. At the onset, the patient may have difficulty in fine movements such as buttoning, writing. The patient may encounter difficulties in walking, such as the patient may have a increased incidence of tripping or foot slapping because of the paralysis of the dorsiflexors. For bulbar onset, there may be changes in the voice. Okay, for example, there is difficulty in pronunciation, difficulty in movement of the tongue, movement of the lips because of weakness. These are all impairments related to lower motor neuron pathology. Specifically, while talking about the posture, the cervical extensor muscles are very weak, right? The cervical extensor muscles are typically weak, so the patient has a flexed neck posture. Also, the patient may feel heavy headed after prolonged writing or reading. As the weakness progresses, the flexed posture of the head becomes prominent, and this may lead to development of cervical pain. Then the muscle weakness leads to reduction in range of motion, joint contracture, tendon shortening, adhesive capsulitis, right? There is impaired postural control and ambulation difficulties, deconditioning as the patient becomes bedridden in the later stages of the disease. The foot drop is a very common sign because of the paralysis of the tibialis anterior. The pattern and progression of lower extremity weakness are characterized by greater losses of the muscle force in the distal muscle as compared to the proximal muscle. The torque production is reduced in these weak muscles, right? The patients get fatigued very soon. Okay. Also, it is seen that the neurons die, so some of the muscle fibers die, right? So there is a overload on the weak muscles or overload on the muscle fiber, those who survive, right? As the muscle fiber denervate, there is a atrophy because of the loss of volume of the muscle fibers. The other element sign include flaccidity, muscle cramping, hyporeflexia. The muscle cramping may occur at unusual sites such as tongue, jaw, neck, abdomen, calf or thigh. One of the typical feature here is that the sensory pathways are always spared. Only and only you will be encountering motor abnormalities. Now, impairments related to upper motor neuron pathology. This is similar to any upper motor neuron pathology, which is characterized by spasticity. Okay, there will be hyperreflexia, clonus, pathological reflex such as Babinski and Hoffman sign is present. Now, impairments related to bulbar pathology. In bulbar pathology, you get a mixed picture of upper motor neurons and lower motor neurons, right? There is a spastic or flaccid paralysis or a combination of both. There is spastic dysarthria, there is flaccid dysarthria. Dysarthria is a speech impairment where the articulation of the speech is difficult. In flaccid dysarthria, there is weakness of the tongue muscles of jaw, larynx and pharynx. The initial symptom of this is the patient is unable to produce voice, or is unable to project the voice in certain movements such as singing, which has a high pitched and a low pitched combination voice. In those kind of activities, you will be seeing a disarticulation where the patient cannot shift from high pitch to low pitch. Then the patient may have difficulty in pronunciation of certain words which require a combination of both the pitches. Then shouting, where the patient is unable to project the voice forward. In spastic dysarthria, a more effort is required to project the voice, okay, whereas in flaccid dysarthria the voice is hoarse. Anarthric, where the individual typically just cannot articulate the words. Now dysphagia is difficulty in swallowing. There is impaired chewing because of either spastic or flaccid paralysis or combination of both. Patients experience siluria, that is excessive drooling of the saliva because of the weakness of the jaw muscles to keep the lips tightly closed. Then there is a typical feature which is known as pseudobulbar paralysis. In pseudobulbar paralysis, there is a pathological emotional control, right? There is a pathological emotional control where there are related episodes of laughing and crying. See, in such patient it happens that there is no particular stimulus, there is no particular emotional stimulus which can make the patient laugh or cry, but the patient has spontaneous episodes of laughing and crying, which is known as pseudobulbar effect. Talking about respiratory impairments, also the respiratory muscle strength is reduced, there is a decrease in vital capacity, and the early clinical features here are fatigue, dyspnea. Dyspnea is difficulty in breathing on exertion, difficulty in sleeping supine because of the position of the diaphragm. This dyspnea can wake the patient up in the middle of the night. Due to this dyspnea, there occurs hypoxia, which manifests as a headache, as a morning headache. Then there is a recurrent sighing or are gasping for air in supine, right? Moving on, the last portion here is the cognitive impairments. Whenever the frontal lobe is affected, the patient will have severe frontotemporal dementia, which is characterized by decline in cognitive function, executive function, difficulty in planning, organization. Whenever the frontal lobe is affected, always remember that there will be personality changes, behavioral changes, impairments in verbal fluency, memory deficits, impairments in general intellectual function. So this was completion of part 2, which consisted of clinical features of motor neuron disease. Thank you.